Good morning. I'm Margaret Foster Riley, otherwise known as Mimi Riley. I'm one of the co-directors of the Health Policy Project here at the Miller Center. It is my great pleasure today to present the new book of my colleague, I should take the pen off, of my colleague, Guian McKee, also a co-director of the Health Policy Project, Hospital City, Healthcare Nation. And that is going to be the focus of our book talk today. I'm going to be asking him questions as we go along, but there will be an opportunity for you in the audience, both online and in person, to ask questions. If you are in the audience here in the Miller Center, please write your question on one of the cards that's been distributed around. If you are online, please write your question at the bottom of the screen. You'll see a place to put questions, and if you put your question in there, it will get to me, and hopefully we'll have time to address all of them. Guian, this is just a terrific book, and it's just so exciting. I have to say, I'm a health policy expert, but for me, it answered questions in a way that I have never seen before. One of the great conundrums in healthcare is, how is it that the United States spends so much money on healthcare and yet Americans are not healthy? Certainly not healthier than many of European countries or other moderately developed countries. Guian's book explains this in a way that is unique. There are books actually about the development of health reform in the United States, looking at the political structures as they went along. There are lots of articles and books on healthcare economics, but I think it took a historian to actually pull it together for us. What Guian does here is he moves through the evolution of a major healthcare system, Johns Hopkins, its relationship with the city of Baltimore, developing into what he calls the hospital city, and alternates it as you go along through the book with different chapters in the development of national healthcare reform. And within that, you start to understand how capital flows, how that built what we now think of as a modern health system, and became a major engine of the economy, but not necessarily one that actually improves healthcare for all Americans. And so that's the basic structure here, and we're going to try and move through that structure so that you can see where that capital flows and how we got where we are. So Guian, before we start, tell us how you came up with this idea.
Well, first of all, thank you for that introduction, Mimi, and thanks to everyone, both in person and online, for joining us today. And this is a project that goes back for about a quarter of a century in its earliest origins. I haven't been writing it that long, don't worry, but the ideas have been germinating. And the starting point was really with my PhD dissertation and then first book, which was about deindustrialization in the city of Philadelphia and the way that federal and local policies interacted in trying to deal with that problem, and ultimately, in a lot of respects, really failing. And when I was doing the research for that project, I was going into archives in North Philadelphia, center part of Philadelphia, researching the disappearance of the old industrial manufacturing base. Meanwhile, my, now wife, we weren't married then, was working in a research lab at Children's Hospital of Philadelphia. So my lived experience was I would take the train into North Philadelphia, past abandoned factories and declining neighborhoods in real crisis at the time in the 1990s and early 2000s. And then in the evening, I'd go down to West Philadelphia and get off the train into this massive complex of hospitals. the University of Pennsylvania Hospital, Children's Hospital, just down the road, Jefferson Hospital of Philadelphia. And these were thriving, massive institutions that, it quickly struck me, were the leading employers in the city of Philadelphia in this post-industrial period. And that this was actually the endpoint, at least to that time, of the story that I was telling about deindustrialization. This was the what came after. Now, in that book, where I had a lot to deal with in terms of the core subject, I've got a couple paragraphs, I think, in the conclusion, kind of a hand wave to this point about what comes after, but it stuck with me. And it was really motivating to think about a next project of what does it mean when you have these kind of massive structural economic shifts? And so I started looking at healthcare, and I was teaching in the history department here and the public policy school. And it quickly, as you study healthcare and teach about it, struck me that we spend about 18% of gross domestic product in the United States on healthcare, more than any other advanced economy in the world by about a third. Germany's next at about 12%, if I remember the recent statistics right. And what hit me coming out of the Philadelphia experience was that this has a consequence. This plays out in every community in the country, because Philadelphia, and as I've written about now, Baltimore, is actually very typical that healthcare, because of that economic weight, is the largest employer, a massive economic presence in just about every American community. Big cities, absolutely, but also smaller communities as well, and rural communities. And no one had really written about the implications of that for the healthcare system and for the politics of healthcare. Everything in the policy world and the political history world was very abstract. It was a national level debate. And this is, I think, what I tried to do with this book, to connect those two pieces together, to make healthcare less abstract, to make it community-based, and to show the interplay between the local and the regional and state level and federal policy. And there were a lot of choices along the way and challenges along the way, but I think that's probably the core of this book, and I hope the accomplishment of this book.
I think it succeeds.
Thank you. That's reassuring.
Could you explain what you mean by a hospital city? You started to, but I'd like so that people understand.
It's a phrase that I think does have a lot of import for the book. And it's exactly that idea that hospitals have become such a huge economic actor that they transcend healthcare alone, that they are this central institutional presence in American communities, economic and in many cases political and social as well. I mentioned their role as employers, but increasingly hospitals are taking on sort of quasi-governmental roles as well. Places like Johns Hopkins very recently have been involved in neighborhood redevelopment, in building schools, often more problematically things like policing. And to me, that's a fascinating outcome of this economic structure and the way it's financed and the larger political economy of the United States in the 21st century, that we have these institutions, either private or quasi-public in some cases, that are not the government, but are taking on these kinds of governmental roles. And it's because of largely because of this underlying economic power in relation to the larger structure of our economy.
And I think you show very well in the book that Baltimore and Johns Hopkins are not unique, they're examples. Right. And in fact, you might even see some of this play out in Charlottesville.
You do, on a smaller scale, you really do. Yeah. And one of the interesting things about Charlottesville is how much we are a microcosm in many respects of larger cities.
So the book opens with Hill-Burton, and this begins the origin of what you are calling the hospital city. What were the choices made at a national level, and how did those choices build this hospital city?
Yeah, this is a debate that has its roots really going back into the 1920s and certainly the 1930s about what the central focus institutionally, structurally, of the American healthcare system should be. And we kind of assume the centrality of the hospital today. The hospital is always going to be, obviously, a part of any healthcare system. But the question is how pervasive, how it should be structured, how organized that system should be. And a series of studies during the 1930s and into the 1940s showed that many American communities simply lacked enough hospital capacity. And this was particularly coming out of the Depression and World War II, and resources really hadn't gone in to building new hospital infrastructure. There'd been a building boom in the 20s, but that had largely dried up during the Depression and World War II. And there was a legitimate shortage of hospital beds, of actual need. But the argument that gets made by largely the American Hospital Association, but with support from physicians as well and people in the federal government, is that the hospital needs to be the central focus of the system. And this is challenging other approaches that emphasize primary care, clinic-based approaches to medicine, and even different ways of financing healthcare, to do it through prepaid group practices that would operate communities that would feed into a hospital system where more advanced services would be more centralized. There are trade-offs in that. There are advantages. There would have been advantages to a system like that. I think we've even seen some of the implications through the pandemic of not having that kind of system. There's some advantages to having sophisticated hospital care dispersed around the country. That's what Hill-Burton did. It was a legislation that was passed in 1946 and essentially provided federal matching funds for the construction of hospitals all around the country. And you built hospitals, particularly in the early years of the program, especially in more rural areas, small communities, and suburbs. A lot of it actually went into suburbs. So we ended up in, at least as a starting point from Hill-Burton, with a very hospital-centric healthcare system, rather than a system that might have emphasized other approaches to delivering at least basic medical care. An implication of that today is because we have hospitals in many rural, smaller towns, smaller cities, in a period of real economic struggle for those areas, a lot of those hospitals are having trouble surviving today because of population loss, because of issues with payment rates for Medicare and Medicaid, which is a high percentage of their patient base. And it's actually an ongoing debate within the Biden administration and Congress about what to do about that right now. But Hill-Burton is, at a fundamental level, a way to provide capital for the hospital system, to build out new facilities, to invest to some extent in new technology. This is supported by investments in medical research, where a grant will often, particularly this is more for teaching hospitals, but a portion of a research budget can get apportioned to essentially the cost of the facility in which that research is done. Funneling a lot of capital through public grants into the hospital system. And this starts to supplant the more traditional system of hospital financing, which is earlier is almost entirely philanthropic, basically large donations. It doesn't, of course, completely go away. It remains a part of hospital finances to today, but you see a shift beginning in the mid-40s towards public support for this boom, this wave of hospital construction around the country.
So chapter 2 shows what a great writer Guian actually is, because he really makes people come alive. And it's a story, a sad story, about urban renewal and the growth of the hospital city. And that the urban renewal and the hospital city create financial incentives that ultimately have bred great distrust, disappointment, and the same pattern has played out across many cities across the United States. Tell us about that.
Yeah, so urban renewal has had a lot of attention in recent years because of the damage that it did to many American communities. It was a program that essentially provided federal subsidies, or write-downs as they were called, to acquire and clear urban land that had been declared blighted, essentially deteriorated conditions, lack of infrastructure, a whole range of things to get a community declared blighted. And the reality was that it typically targeted lower income and often minority communities. And often that was done in the interest of kind of large commercial real estate interests, rebuilding often heavily towards central business district infrastructure, and clearing a lot of housing. There was public housing constructed as well, but it was often essentially reconcentrating low-income people, and particularly often African Americans, in essentially what Arnold Hirsch, the great urban historian, referred to as what became the second ghetto. And the thing is, we've tended to emphasize those kinds of central business district, real estate, and commercial interests, but urban renewal was also done by institutions, universities and hospitals. University of Chicago was a pioneer in this, incidentally, but Johns Hopkins Hospital engaged in it as well. And there was get into some details here, but in the late 1950s, Congress had an amendment to the Housing Act of the United States that essentially allowed the use of urban renewal funds directly for hospital and university urban renewal without any real provision for the creation of housing, which had been a condition of the original legislation. And Johns Hopkins is located in East Baltimore and separate from the main campus of Johns Hopkins University, key detail. And East Baltimore at that time was undergoing transition. It was an older neighborhood. Much of the housing dated from the late 19th and early 20th century. It had been occupied previously by a range of European immigrant groups, sort of a classic urban pattern of chain migration and succession of different groups. By the time you get into the post-World War II, you were starting to see significant racial turnover, that it was becoming a heavily African-American neighborhood. And Johns Hopkins had been, hospital had been created in the 1890s, and it was essentially landlocked. There was no open land that it could easily expand as it's facing this period of demand and new growth and a need to compete with other hospitals and a need to rebuild its physical plant. And Johns Hopkins essentially, through a complex series of negotiations with the city of Baltimore and the federal government, gets access to urban renewal funding. And the initial plan that they put forward was one that actually would have included actually segregated apartments, some for medical students and residents, but also some for people in the neighborhood which would have actually been entirely African American. There's a whole story there about what was permissible in terms of segregation in publicly funded housing development, and it was changing rapidly at the time. But the promise was that this African American neighborhood that was going to be displaced by urban renewal clearance would be rehoused. Over the years, and this is one of the things about urban renewal, was that it took a long time. It was a cumbersome process. There was essentially a change in what the federal government would insure in terms of mortgages for the kind of housing they had planned for African Americans. And they lost the mortgage insurance. The developers felt they couldn't finance the housing for African Americans. Hopkins was unwilling to step in, even as they stepped in to provide financing for the housing for their own people. And the sum of it was that the African American rehousing was completely cut out of the project. And they ended up putting in a shopping center, a hotel, a Sheraton hotel, which ultimately went out of business for a long chain of reasons. The housing for medical students and residents, and then there's this massive asphalt playground adjoining a high school in that area, and the community loses any access to new housing. And the reasons are complex, but the ultimate reality of it was that there was an indifference to those needs and to the costs that were being imposed, ultimately for the interests of the institutions. And yet the people in the community don't necessarily know the nuances of federal mortgage insurance policy and how it's shifted. What they do know is what's happening in their neighborhood. Housing is being cleared and nothing is being rebuilt for them. This builds on all kinds of existing history of, and you may even be familiar with some of this, with things like the Henrietta Lacks story of, I guess, a callousness, we could say, on racial grounds towards both research and treatment of people in the neighborhood surrounding Johns Hopkins. And when you then have this massive project that goes in that costs people their homes with no, and then the going back on this promise, as it was very much perceived, of new housing, it creates a tremendous level of distrust. This is the kind of decision that when you make it may seem insignificant if you're the leader of Johns Hopkins Hospital, but it has consequences that reverberate for decades, really right up to the present in East Baltimore, because these stories get remembered. They are not forgotten by the communities that are affected. We see the same thing in Charlottesville, incidentally, with stories like the Vinegar Hill Urban Renewal Project, done by the city, not the university, although there is a UVA story with the Gospel Hill neighborhood, which is not federal urban renewal, but that's aside. But the point being that a powerful institution, one of the few in that community with any real resources, not fulfilling a promise and causing harm is something that is remembered and builds distrust. And it creates a legacy that Hopkins wrestles with, particularly during the period in the 60s and 70s of the civil rights movement and social movements generally. One last thing about urban renewal. I mentioned that Hill-Burton was about providing capital for hospital construction. Urban renewal is effectively the same thing. We don't often think about it that way. Very little of the literature talks about it in those terms, but again, this is part of the flow of new capital for hospital construction, in this case coming directly through urban renewal grants from the federal government. So again, this sort of shift in overall patterns of hospital financing.
So let's move on to another source of capital. There's no question that the passage of Medicaid and Medicare was a triumph for the Johnson administration. But famously, Johnson did not allow any budget projections to be made with either Medicaid or Medicare. And as the administration turned to implementation of Medicare and Medicaid, it was pretty apparent immediately that there were going to be cost problems. One of my favorite quotations in the book is from Kermit Gordon, who was an economist who advised both the Kennedy and the Johnson administrations. And he was actually also later head of Brookings. He was working on the implementation and he runs into someone in the elevator and he says, I want to make sure I get it exactly right. He said, he was all that stood between the American Hospital Association and all the gold at Fort Knox. How did Medicaid and Medicare accelerate the accumulation of capital by the hospitals?
Well, first I should, of course, say, as you alluded to, Medicare and Medicaid have been hugely consequential. The expansion of coverage that they provided for particularly the elderly, but also lower income and people with various disabilities, has been incredibly important, and I don't want anybody to minimize that. It's probably the most effective single poverty reduction measure we've ever had in the United States, or certainly one of, or maybe one of two. That's another conversation. But they also were structured very much in relation to the healthcare financing system that had evolved by the mid-1960s. To give a very rapid history of that, private health insurance had begun to emerge the very late 1920s, first with hospital insurance. The Dallas public teachers in the Dallas public schools were the first insured, employer group insured policy through Baylor University Hospital in 1929. And that was a model that spread very rapidly, particularly during World War II, for a bunch of reasons related to wartime price controls, federal subsidy of benefits. But the point being that by the time you get to the 1960s, employer-provided health insurance has become the norm. It's what my former colleague, UVA history PhD Christy Chapin, describes as the insurance company model of healthcare financing. And what had evolved for hospitals is that they were reimbursed on the basis of reasonable costs. Now, what does reasonable cost mean? What it meant in practice was that the insurance companies would accept a calculation of a total hospital cost divided by the number of patient days in a year, and that was the reasonable cost. This was not a sophisticated accounting system. This is in the days before computers being available on a widespread basis. Basically, nobody really understood what hospital costs were very well, but this was the standard that had evolved. And the Johnson administration, before that, the Kennedy administration, had enough problems with the American Medical Association that was powerful and adamantly opposed to Medicare. And they desperately did not want to have the hospital industry go against them as well. So they essentially accepted the idea that Medicare and then Medicaid, as it's added at the last minute, would pay on the same basis, reasonable costs. And the legislation essentially specified that. That's wonderful, but that's not really the kind of rule that the Department of Health, Education, and Welfare can then actually implement in terms of running a massive new program like Medicare. So this is essentially kicked down the road to the rulemaking process. And here we're getting into the way government actually operates. We pass legislation, but then we have to figure out the actual rules of the road. And they set up a group known as the Health Insurance Benefits Advisory Commission, which gets to work right away. Kermit Gordon is the chair of that, and it has a wide range of representatives of various healthcare interests on the board, including leading the hospital contingent, Russell Nelson, who was the president of Johns Hopkins Hospital at the time and had led the Urban Renewal Project and was a major figure in the history of Johns Hopkins, but also extraordinarily powerful as a healthcare leader in the United States. And there's a series of bitter fights within this commission, the Health Insurance Benefits Advisory Commission. It almost breaks down, and basically the hospitals have the leverage here, because if they aren't going to play, Medicare's not going to work. You're not going to be able to roll this out. And the deal that is essentially struck is that they will get cost-based reimbursement as they've been getting for the insurance companies, that there will not be any kind of effective limitation on those standards that the federal government will pay. Not only that, they will get an allowance for capital. Essentially, the formula that is developed is hospitals' costs plus 2% will be reimbursed through Medicare and also Medicaid. Now, cost plus pricing is a great deal if you can get it. Think about what that means. And your costs, and then 2% of your costs you're covered. And as your costs go up, that 2% grows. It's even better than that, because in the cost calculation, they're allowed to include interest expenses and accelerated depreciation of their physical assets. So it's an extraordinarily beneficial formula that gets applied through the rulemaking process for hospitals. And what this does is that not only do you have a new flow of direct payments to hospitals through Medicare and Medicaid in the early days for care that had often been done on a charity basis or not at all. So there's just direct new revenue streams, but you also are getting your capital costs funded. So what we see then is, again, another source of revenue for hospitals to build out reserves to improve their financial position, because many hospitals, including places like Hopkins, are actually struggling financially. Hopkins runs losses for decades before Medicare and Medicaid come on the scene. And it allows you to do something else. If you're a hospital administrator or a hospital board wanting to compete with the hospital down the road or the hospital out in the suburbs, you want that expansion. You want that new wing or new building or new equipment. And yeah, there's Hill-Burton, but that's limited. There's research funding, but that's limited. The other place you can go is to take on debt, to go into the capital markets. And that's what hospitals do rapidly and on a massive scale as you move into the 1970s. They are able to do that because of the revenue streams that Medicare and Medicaid, along with the underlying private insurance model that's now fully developed, creates. And particularly this funding of capital through the system. And you see places like Hopkins, as they prepare to renovate their physical plant in the 1970s, going to Wall Street. And I have an account of some of the detailed meetings, and particularly a place like Hopkins, the leading firms on Wall Street are thrilled to get this business. This is prestige business. You've got this guaranteed underlying stream of revenue. And so they can take on tax-exempt bonds, or in some cases, taxable bonds, to raise capital, to expand, to get the newest technology, to build the newest facilities. And so this creates then the third phase of hospital financing. You move from voluntary philanthropic support to the public grant support to now the debt markets. You're engaging, in other words, with major structures of essentially the larger capitalist economy in the United States as the way that you're going to fund this massive segment and growing segment of the healthcare industry. This is true if you have those revenue streams, okay? For your more prosperous hospitals that have a high percentage of Medicare, a high percentage of private insurance, they're in great shape because they have the revenue to allow themselves to qualify, to issue bonds, to expand, to compete essentially on the services and the amenities that they're offering. Hospitals, though, and this is where we get into one of the huge consequences that's playing out right to this moment, hospitals that don't have that base of either patients who have Medicare or private or are privately insured don't have access to that same increase in revenue. And they're not able to take on the kind of debt to enter the bond markets the way a Johns Hopkins or the way a prosperous hospital in the suburbs of Baltimore or Washington can do. A case of this that I talk about in the book is Provident Hospital, which was the African-American hospital historically in the city of Baltimore. Long and complicated story. There are other factors, but basically, Provident is not able to get this kind of investment by about the late 1980s. It first merges and then eventually closes completely. So in other words, that's an extreme case where a hospital closes, but this plays out across the system, that you get greater inequity between different hospitals based on the categories of patients that they serve. I've sort of merged Medicaid and Medicare together. Medicaid, of course, is more focused on lower income people. Very rapidly, because of the way Medicaid is structured, it becomes significantly less financially useful, I should say, for hospitals because it pays at much lower rates. There are issues later on that we have today with Medicare itself and how much it pays hospitals, but this early period, Medicare is very beneficial to the hospitals that have a high percentage of insured patients.
So cost has become a problem.
And cost becomes a problem. Costs skyrocket in the 10 to 15 years after Medicare and Medicaid pass, because you get into this competitive spiral of more spending, of incentives essentially to spend more, to make more investments in facilities. And I should say this is a very competitive period, but this is not the kind of competition that free market economists talk about, competition on price. There's no way, and there's some wonderful research done during this period by an economist named Kenneth Arrow, who wins the Nobel Prize for this. Basically, there's no way to assess prices and value in a kind of classical perfect competition kind of a model. Markets don't work very well in healthcare. That's what Kenneth Arrow says in 1962. And so the competition that you have is based essentially on amenities, on services, on facilities, and it's one form of competition that doesn't encourage efficiency, and all of this builds together to an upward spiral of costs. Not just driven by hospitals, physicians are also increasing, that cost is increasing as well, but hospitals are the leading force in this.
So now we're in the 70s. Now, Nixon comes into office with very limited interest in national health insurance reform. But he gets pushed there by Walter Reuther from the United Auto Workers, and with the arrival of Senator Ted Kennedy, who is staging a comeback after Chappaquiddick and focuses on health care reform as an issue and interest for the rest of his lifetime. So Nixon takes a new tack. He's focused on cost controls, which is a general focus of the administration, a new managed care model. And that managed care model is going to form the core of his proposed policy. And it has bipartisan support. Why does it fail?
Well, Nixon is a complicated story because
in many
ways. Yeah, we could spend the rest of the time analyzing his psychology as to why he takes this on. Couple of pieces about Nixon. The managed care piece actually, to some extent, is the one piece of legislation that makes it through during the Nixon period. The passage of legislation in, I guess, 1973 that creates new capacity to create what are known as health maintenance organizations. And that, at the time, I mentioned prepaid group practices earlier, and this is an old progressive idea, basically that rather than have medical services reimburse, cost per cost, procedure by procedure, what we know is fee-for-service medicine, that if you change the economic model and have subscribers pay a monthly fee that the physician or the clinic or the hospital gets, you smooth out revenue streams, but you also remove any incentive towards overtreatment, that it's a better alignment of incentives for everybody involved, and it can increase quality of care, at least that's the argument. But it's also a nonprofit model. And what Nixon does, and there's a long story here with a physician named Paul Elwood out of Minnesota who pushes this, and Alan Enhoven at Stanford a little bit later on, is to say, well, it can be nonprofit, but it can also be for profit. You can run this as a business. And they changed the nomenclature to health maintenance organizations. And the early stages of this aren't very successful. There are a lot of restrictions on it, and it's not till the 1980s that it actually begins to take off. Ted Kennedy, as you said, it's got bipartisan support. Ted Kennedy actually agrees with this, and is ultimately, Nixon kind of drops it, and Kennedy is the one that pushes that piece of legislation through, because it's got this old and a progressive element to it. And Kennedy believes that this is a good way to change the basic incentives of medical care and start to restructure this model of financing that I've just been talking about. Now, for him, it's part of a much larger project that would involve national health insurance, basically federal insurance for all Americans at this point, literally from the first dollar of cost. There's no cost sharing. Cost sharing is a new idea in the 1970s, that you'll have complete coverage. The other thing that Nixon does is that he says, wait a minute, I need to counter Kennedy because he might run against me in 1972 or maybe 1976 if we get there. And I need to have not just HMOs, but I need to have a coverage model. And what Nixon essentially does is he says, well, we're going to keep the private insurance companies involved in the game. And he does that, and there are a couple of versions of this plan, but he introduces the concept of a mandate. It's initially Nixon, and it's on the employer side that all employers must provide coverage for their employees. And there are various subsidy structures that go along with that. And his model also involves working with the states to provide subsidies for private insurance coverage. So you see in the big picture, these two contending models of one that would completely replace private insurance with a public system, a single payer, or if you like current terminology, a Medicare for all kind of a system, or one that builds on the existing system that uses market mechanisms such as they exist and that preserves a significant role for private insurance. Nixon also includes cost sharing, that it won't be first dollar coverage. And this is an idea that's introduced from economics, and it's basically early stages of behavioral economics, that if you have patients who have some skin in the game, that they have to pay part of their coverage costs, they will be more effective consumers, that they will consider the costs of whatever procedure that they're going to undertake, and that you'll end up getting efficiency through that side as well. How that works out over time is pretty complicated, and that's a longer conversation, but that's really where you start to get this idea introduced. Nixon reintroduces the proposal in early 1974. It's essentially a distraction from some other political events that are going on in Washington at the time, which we don't need to go into. But the thing is, it comes very close to succeeding. Kennedy, by this point, is willing to negotiate, and you've got a lot of backroom negotiations. There's one famous story where a Kennedy advisor and a Nixon advisor are at some conference in New Mexico, and they ride a ski lift up a mountain and start negotiating. How can we find a compromise? And they bring in Wilbur Mills, who is the famous chairman of the House Ways and Means Committee at the time, one of the most powerful individuals in Washington, and incidentally one of the most knowledgeable about social insurance and tax structures because of that role in Ways and Means. And for a while, it looks like they might actually get a deal through. At least it looks that way publicly. Kennedy and Mills are sending negotiators out to negotiate in the basement of a church in Washington to try to keep this secret. Nixon, of course, is going on to his retirement in California. A couple things happen. Kennedy is close to reaching a deal with Wilbur Mills, and he can't bring the labor unions along. They are hoping in the aftermath of Watergate that they're going to have a massive Democratic victory in the midterm elections and then potentially in 1976, and then they can get the whole thing. Because the deal with the Mills involves compromise. At that point, Kennedy's accepted cost sharing. That's the big give. It's still national health insurance, but the unions won't go along with it. Kennedy backs off. Wilbur Mills, how much do we want to talk about Wilbur Mills?
Unfortunately, only a small amount.
Let's just say he has a spectacular personal explosion that involves an exotic dancer, an episode in the tidal basin in Washington, and then an appearance on stage with said exotic dancer in Boston. You have to read the book. It's a tragic story, actually, because Mills is a man of incredible ability and insight, but also has a problem with alcohol, and it destroys him. And he's forced to resign as chairman. And you move into the Ford period, and the momentum evaporates. They don't have the support they thought they'd have for a compromise bill. Nobody else can really replace Mills and the ability to get legislation through Congress. And this opportunity, arguably the best we've ever had, is lost. And these are bills, I mean, whatever you think about the Affordable Care Act, there is an elegance and a simplicity to some of these bills that get talked about in the 70s that, you know, we would have had a starting point in 1975, and we still had a Congress that was reasonably functional. You might have had time to improve that. We'd be in a better place today had you passed some of the legislation that's considered in the 1970s.
So speaking of tragedies,
yes.
One of the stories you recount in the book that's not that well known is the battle between Senator Kennedy and President Jimmy Carter for essentially the soul of healthcare reform. Right. It's a story of lost chances. Yeah. Tell us about that.
Yeah, this is a story, particularly on the Carter side, that most historians have really discounted. There's one really a very good account of presidents and healthcare reform that refers to Carter as the righteous engineer, that he was impractical, that he was rigid. There's a lot of truth in that. But the thing that I point to with Carter, I think true to his character, is that he looked at the healthcare situation and quite correctly basically said that this is a system where the costs are way too high, and that the core driver of those costs are hospitals and the way that they're paid. And he wasn't particularly drawn necessarily to healthcare as an issue, but it was important. You know, Ted Kennedy is still there. He's actually gone back at this point to a pure the pure national health insurance approach. The Mills Compromise is dead, and he's now talking about it, national health insurance, no cost sharing. And he's pushing on Carter to go in that direction. Carter's unwilling to do that. He's coming out of Georgia. There's a wonderful book by another UVA PhD that's also coming out, same publisher's Mind, that talks about Carter's background. And Carter believes in public-private partnerships, like at the very, in his very political core. And so he's unwilling to do that with Kennedy. He wants to find a compromise measure with the existing system. But even more than that, he says we have to deal with the cost problem first, because we can't afford this. And of course, in the 1970s, you've got high inflation at a level that makes what we're dealing with now high inflation, and of course a bad economy, and persistent, really persistent inflation. And first of all, there's no political way to get a national health insurance bill through what's still a pretty conservative, even Democratic coalition in Congress. Carter knows that. Kennedy doesn't have the votes. And Carter tries to put a hospital cost containment bill through as a starting point for his healthcare agenda. We can talk a lot about the complexities of that bill, and there's some limitations. hospital cost accounting has gotten better by the 1970s, but you're still really figuring out how to make a sophisticated assessment of what hospital costs and even prices actually are. And Carter's model is essentially an overall cap on revenue nationally to be allocated through regional health planning systems, which are established but very weak, and also a cap on total capital expenditures. It's a pretty crude bill in a lot of ways, but the basic principles that it lay out were serious. And again, I talked about the base that could have been provided by some of the Nixon and Kennedy bills in the 70s. It's sort of the same thing, I think, with the hospital cost containment, that it would have given you a basis to do more rigorous planning at regional and local levels as to how the hospital system is actually organized, and you would have shifted the financing basis. This essentially is a challenge to the status quo. And the American Hospital Association and other hospital groups mobilize every resource they have against it. There's a quote I have in the book from, I guess she was, Ann Wexler is Carter's Director of Public Outreach, I guess was her title. And she makes the point that every community around the country has a hospital, and on that hospital's board sits every influential member of that community. And when they decide to mobilize against legislation, they can reach every member of Congress in the country. And they can do it in a way that has a great emotional appeal. And this is where perhaps the righteous engineer thing has some validity. The argument that Carter's making, that I'm, I guess, making as well, is a technical one. It deals with all these nuances of financing that have critical implications, but it's really hard to make an emotional pitch that we should limit the revenues of, I don't know, I'll pick on Martha Jefferson, our friendly hospital down the road, I need to pick on Martha Jefferson, this is a national issue. But it makes the point that the locality of these institutions and the way that they can mobilize political power. So long story short, Carter tries and tries and tries, can't get hospital cost containment through. They get it through the Senate in a modified version, and I guess it was 1978, because basically the hospitals fell asleep, and Kennedy incidentally supports this part of Carter's agenda, and Kennedy gets it through, but it dies in the House. Meanwhile, again, a lot of nuances and details, but Kennedy gets increasingly frustrated with Carter's unwillingness to simultaneously move forward with some kind of a national health insurance plan. And he's open by this point to compromise, but Carter does not want to push a bill, he's already losing on hospital cost containment, that he doesn't think he can afford, or that the country can afford, and that he isn't sure he can get through Congress. He doesn't want to take another domestic defeat. And he basically kicks this down the road past the midterms to 1979. Negotiations with Kennedy break down. Carter eventually in 1979 introduces a bill that essentially is provides catastrophic coverage for Americans, and also, interestingly, federalizes Medicaid. It essentially merges Medicaid and Medicare together into a program known as healthcare, which is actually a fascinating idea. There was still state costs involved, like the states would have essentially been financing part of the cost of that coverage. But it's actually a pretty innovative and interesting idea. There's a whole thread here of what we could talk about with Medicaid. But it's a limited package. Carter says this is phase one. We're going to gradually expand this out. Congress will act as economic conditions allow. Kennedy, although he's open to, at this point, compromising on involving private insurance companies, his proposal by 1979 actually relies almost entirely on subsidy of private coverage. So you've seen a real shift in Kennedy's approach. But what he is not willing to compromise on is the idea of phasing. He wants it all now because he doesn't believe that Congress will follow through. And he ironically points to hospital cost containment as evidence of that, that that the lift is too hard, you're not going to be able to do this repeatedly. So you have this kind of clash of philosophies, and they're sort of both right in a sense. It is, as we've seen, a huge political lift to pass healthcare legislation. At the same time, in 1979, inflation and the budget deficit are massive problems, and even beyond what we think about them in terms of the budget and the economy, they're a massive political weight on the president. And Carter's also correct that he can't even get this limited bill through. He certainly can't get what Kennedy wants through. So again, you have real pieces of policy development, policy advance, and you're also starting to think about some mechanisms internally within health education, or I guess it's health and human services by this point, about how to do more sophisticated cost control systems at the federal or the state level that would provide the basis for something really more substantive, for really substantive, meaningful reform, but you're not able to find the political positioning and compromise to get this through Congress, given the economic upheavals of the late 1970s. And I guess we can say some of the limitations of the politicians involved. So, as we think about President Carter's legacy, I think this is a piece that's underappreciated and really not very well understood, of real insight into the policy issues at stake, a degree of political courage in taking on a piece that, frankly, our leaders are still dancing around in terms of healthcare costs, but then a breakdown of an ability to find the kind of compromise that would have advanced some of these policy solutions into law.
So I'm going to move history along fast now.
Yeah.
We're not going to talk about the Clinton piece because, unfortunately, it's a story mostly of failure and isn't going to add that much to here. But I do want to focus on something that is unique to Maryland. And it will help us tie together some of the things that we might consider as we think about how to bolster the ACA against some of the currents that you're describing here. And so the rate setting system in Maryland, some other states tried it, failed, but Maryland's had succeeded. And so the Health Services Cost Review Commission has survived. What is it that it's doing right? How is it, including Hopkins, all the stakeholders are relatively satisfied with this rate commission, and it is helping to bring costs under control, and yet it is not stymieing growth at the same time?
Yeah, so again, we go back to this period of ferment in the 1970s, and I've talked mostly about the federal level and these kind of high-level clashes. Another thing that's going on is state-level experimentation, and the motivation for that is Medicaid. Medicaid comes online same time as Medicare. Medicare's rollout in the scheme of things is very smooth. Medicaid goes really badly. And again, it's these cost estimates that haven't really been done fully, that aren't complete. And the costs for state governments under Medicaid rise incredibly fast. And it's a huge burden on state budgets. And so you see a series of experiments in states around the United States with how to contain these cost rises. What Maryland and a number of other states do is they implement what's known as an all-payer rate system. And there are complicated formulas involved, but basically it means that every payer, whether it's an insurance company or a private individual, Blue Cross Blue Shield, or crucially Medicare and Medicaid, pay the same rates to hospitals. And this is a hospital system. And it initially doesn't involve, for a long time, it doesn't involve physicians at all. And the Medicare and Medicaid piece is critical. They have to get a waiver from the federal government to do this. What has evolved by the point you get to the 70s is that healthcare inflation is such that, as expensive as Medicare and Medicaid are, private insurers are actually paying across the board significantly higher rates of reimbursement to providers. And the waiver allows Maryland to set rates for all hospital procedures and services that are consistent. And it essentially smooths out that gap between Medicare and Medicaid and the higher rates that private insurers are paying. Now, this has a couple of implications. It actually, in the short term, think about it, it costs the federal government more money to do this. But the idea is that over time, you control the overall rate of growth, and hence Medicare and Medicaid payments over time, although they're still higher than they might otherwise be, will actually, the rate of growth will slow, and the overall cost of the system will be much, much lower. The other thing that it does is it helps to smooth out the inequities in the system between richer and poorer hospitals, essentially, because you're closing these gaps for a hospital that's relying heavily on Medicaid or even Medicare, is brought more into line with what hospitals with essentially a wealthier, better insured patient base is receiving. Doesn't solve all problems. I mentioned the case of Provident, but it helps really significantly in smoothing those revenue gaps out. It essentially is removing hospitals, to a degree at least, from this kind of competitive behavior that I talked about earlier, that it moves them a little bit closer to being what I would describe as social institutions, that they aren't purely thinking as quasi-businesses in a market that isn't really working efficiently, and creates a more stable operating environment, which is why the hospitals ultimately, and there's some early fights about it, don't mistake me, it's not a smooth early process, and I detail all of that, but ultimately they come around. Maryland makes it work because they keep the system simple. By about 1978, they have a baseline formula that they apply to every hospital in the state. Other states try to do detailed review of every rate in every hospital, and it becomes incredibly complicated. The other thing that Maryland does correctly is that they give the HSCRC the authority to make adjustments without additional legislation. Most of the other states have to go back in and amend their authorizing legislation every time they need to adjust the system. Those, I think, are the key elements. I go through a political process that basically somebody gets something out of everything. So they essentially are able to satisfy all of the major players. So they end up getting essentially a political consensus behind the bill, or behind the system. There is, again, over time, there's a weakness in this system. And for a while, they control for this. But when you're controlling the rate a hospital receives for a service, that's fine. But there's a way around that if you're a hospital administrator wanting to maximize revenue. You increase admissions, you increase the services provided, you essentially increase the volume and intensity of service, and your revenues will, generally speaking, go up. There's a control on this in Maryland until about 2000. This is the period of enthusiasm for managed care and also deregulation. Most other states that have not had as much success have already killed their all-payer systems. And Maryland relaxes their volume control on the idea that managed care will take care of the problem. The difficulty with this is that everybody hates managed care, and that we don't have time to go into that, but managed care is basically losing its ability to control costs effectively by this point. So costs start to go up significantly in Maryland, and they reintroduced a version of that mechanism for a while, but the really critical advance comes in 2014. They negotiate a new waiver with the Federal Center for Medicare Services that allows them not only to set rates, but to set the global budget, a global budget for all hospitals in the state. Basically, that the hospital will receive a guaranteed amount of revenue in a fiscal year, and they make adjustments to the rates over the course of the year to ensure they're not coming in above or below that. So you basically take out that economic incentive to increase the volume and intensity of services. You essentially create a model that says, you have this much revenue in the year, and if you can be efficient, you're going to get a percentage of that savings. If you go over that revenue, you're out of luck. But it's a way to essentially arrest the growth of the cost of hospital services in Maryland. And potentially, you could experiment with this in other states as well. And again, it's that long-term effect over a decade or 2 decades that if you slow the rate of growth of the system over time, you create significant savings, certainly for everyone in the private system, but also ultimately for Medicare and Medicaid. And the initial 5-year run of this experiment created about $1 billion. That's exactly where you cut it off, but $1 billion to $1.4 billion in savings for Medicare. So it's really one piece of the Affordable Care Act cost control mechanisms, because the authorization for the waiver comes out of the ACA. And the ACA mostly punted on cost control, to be very blunt, that we're going to do experiments. This is the one experiment run through the Center for Medicare and Medicaid Innovation that's really shown some significant savings. So this is kind of one of the policy points that I make, is that we can work with the states and figure out what works for local and regional and state level conditions, and think about how to replicate systems like Maryland or modifications of it, because you do have varying conditions. Although I will say, one thing about Maryland, if you think about that state, is you have a large city, you've got large suburban areas, you also have a significant rural component of Maryland. So there is a degree that, in kind of blunt terms, it weirdly is a model for at least economically of a miniature of the whole country. And they've made it work really well across all those different areas. So I see real potential on that. One thing I'll say, kind of the politics of this, is you could work this with an ACA style system, or you could do it if you went to a Medicare for All model. I think one of the more sophisticated models of Medicare for All is the Physicians for National Health Program, and that's about single payer. But they also have a model like this, that they want global budgeting and all payer rate setting. And you don't usually hear that in the political debate. It tends to be all about single payer or not, or market mechanisms. And this is where I think we need a more sophisticated level of political discussion around healthcare reform, that you can't just talk about coverage, you have to talk about costs. And in talking about costs, going back to the community level, you have to be really sensitive to the world that we've built since 1945 or 1920, if we want to, where so many communities now rely on the healthcare industry generally, and hospitals specifically, as their basic means of survival, not just medically, but also materially. This economic significance of the industry is very real. So we can't simply come in and wind the clock back to 1940. We have to take that into account and not simply devastate this industry. We have to find more sophisticated models that smooth out revenue cycles as we make adjustments in the system as it exists.
And we see that play out even in Charlottesville as you look at it.
Yeah, absolutely.
We're running out of time. We could do a lot of more within here. Closing, pull it all together, Guian?
I might have just done that, but I guess I really would come back to that point that I think we need to dial down the temperature on the politics of healthcare and the ideology, and think and move away from some of the kind of assumptions coming out of a real political framework that have driven the debate for the last 50 years. I'd like to get away from those contests between, Bill Clinton and the insurers, or Ted Kennedy and Jimmy Carter, and think in a more sophisticated way about what the next steps might look like in making the healthcare system better, more equitable, and more efficient for everybody. I hope in telling this history, drawing some of these connections together, making healthcare less abstract, I hope, that it plays out not just in Baltimore, but every community around the country. Maybe this book might make a small contribution to that.
Or a large one. So thank you for coming. Get the book.
Thank you, everybody.